everybody, and welcome to our seminar series. This is our seminar on basic biostatistics concepts for radiation oncologists. I'm Leonard from Rhode Island Hospital in Brown. I've long had an interest in simplifying and making relevant biostatistics for oncologists, and particularly for radiation oncologists. Today we're going to start with two really important concepts for biostatistics. We're going to talk about binary testing, so sensitivity and specificity, positive predictive value, negative predictive value, and likelihood ratios. And then we're going to talk a lot about the basic but super important survival analyses that we use in oncology. So for today's lecture, I have a couple of resources. The first is this paper looking at MRI versus mammography for breast cancer screening in women with familial risk. It's from Lancet Oncology in 2019, and we're going to use this paper to illustrate the really interesting concepts of sensitivity and specificity and to show exactly why they're important for us as radiation oncologists. And then I also have this basic biostatistics worksheet, which you should have available. You can use this to follow along and to do calculations and examples for yourself. So let's start with the goals and objectives of this seminar. The goal is to illustrate key biostatistics principles using oncology examples. The objectives are to analyze the relative sensitivity and specificity, negative predictive value, positive likelihood ratio, and negative likelihood ratio of binary diagnostic tests, to analyze time to event data, and to apply these concepts in the clinic. Here's the outline of what we're going to cover. So let's get started with sensitivity and specificity. I'm going to start by giving definitions. I'm going to go through this pretty quickly. The purpose of these slides are just so that you have the definitions all in one place. As far as understanding the concepts, we're going to go through them with an example, so it's a lot cooler to follow along that way. So sensitivity is the proportion of patients with a disease who test positive. And sensitivity is also known as the true positive rate. Specificity is the proportion of patients without the disease who test negative. Positive predictive value is the probability that subjects with a positive screening test truly have the disease. And negative predictive value is the probability that subjects with a negative screening test truly don't have the disease. Whenever we're going to work with sensitivity and specificity, we start with 2x2 tables. And it's really critical that you always make these 2x2 tables the same way. And I kind of hammer that point. So whenever you make these tables, you want to start by labeling the test result all the way over to the left and then filling in the rows with the test result. And then you want to label presence of disease at the top and fill in the columns with presence of disease. And then as you fill in the boxes, A and B are the top row, and C and D are the bottom row. A and C are the left column, and B and D are the right column. And it's really important that you always do it this way, because I've seen how sometimes tricks are kind of thrown in, trying to trick people by switching the presence of disease to the rows and the test results to the columns, and then the formulas don't work. So always remember, test results fill in the row, presence of disease fills in the columns. Box A is for true positives, patients who have the disease and appropriately test positive for the disease. Box B is for false positives, patients that don't have the disease but have a positive test. Box C is for the false negatives, patients with the disease who have a negative test despite actually having the disease. And box D are the true negatives, patients that do not have the disease and appropriately have a negative test. The number of patients with the disease is A plus C. Okay, so here we're going to start talking about how to calculate sensitivity and specificity using 2x2 tables. We know from the previous slide that the number of patients with the disease who had a positive test was in box A. Sensitivity, or the true positive rate, is calculated by the number of patients with the disease who had a positive test divided by the total number of patients with the disease, A over A plus C. And we also remember from the previous slide that the number of patients without the disease with a negative test was D. Specificity is calculated by the number of patients without the disease who had a negative test divided by the total number of patients without the disease. So D over D plus B. And here's a really important tip. You always want to remember that when you're calculating sensitivity and specificity, the denominator is the presence or absence of the disease. So now let's talk about negative predictive value and positive predictive value. The negative predictive value is calculated by taking the number of patients without the disease who have a negative test and dividing that by the number of patients with a negative test. So the formula is D over C plus D. The positive predictive value is calculated by taking the number of patients with the disease who have a positive test and dividing that by the number of patients with a positive test. So that's A over A plus B. Another important tip, you always want to remember that to calculate negative predictive value and positive predictive value, the denominator is the result of the test. So contrast that to the sensitivity and specificity where the denominator is the presence of disease. So if you always remember that sensitivity and specificities formulas have the presence of disease in the denominator, and negative predictive value and positive predictive value have the result of the test in the denominator, it'll help to keep them straight in your mind. So as radiation oncologists, how do we use these concepts in the clinic? So let's imagine that we have a woman come in who's worried about breast cancer, and she asks you, Doc, I have a strong family history of breast cancer. Should I get a breast MRI? And we're going to use this example to help answer that question. The example is MRI versus mammogram for detecting breast cancer in a high-risk population. This is the paper that I showed you earlier. It's a randomized trial where women with a family history of breast cancer were randomly assigned to standard of care mammogram for screening or the addition of MRI for screening. So this paper, they collected data from the randomized trial and they used it to calculate a sensitivity, specificity, and positive predictive value. We are going to do the same and do the calculations ourselves and then compare our calculations to their calculations. So let's get started by looking at the sensitivity and specificity of MRI for detecting breast cancer in a high-risk population. I took these numbers from the paper, and you can do the same. And we're going to use them to answer the question, what is the sensitivity and specificity of MRI for detecting breast cancer? So if you go to your worksheet, this is example number 1, and we're going to start by filling out the sensitivity and specificity 2x2 table. So I have one here and you have one in your worksheet, and we're going to fill them out together. Step 1 is to label the columns, presence of disease, yes or no. So I'm going to do that. And you can do the same on your worksheet. Step 2 is to label the rows, test result, yes or no. And I'm going to do that here, and you can do that too. Now step 3 is to fill in the boxes. So we're going to start with the 2,812 MRI screening rounds and put that in the total box. Then we're going to take the 39 cancers detected by MRI. Those are the true positives, so they go in box A. We're going to take the 1 MRI false negative and put that in the false negative box, box C. Then we're going to take the 449 MRI false positives and put those in the false positive box, box B. Now we're going to use math to fill in the rest of the boxes. You can go ahead and do that for a minute on your worksheet, and then I'll fill them in here. Okay, now we're going to identify the true positives, box A, 39, the false positives, box B, 449, the false negatives, box C, 1, the true negatives, box D, 2323, and then the number of patients with the disease, which is A plus C, 40. We're going to use this 2x2 table to calculate sensitivity and specificity. So let's start with sensitivity. That's the number of patients with the disease who had a positive test divided by the total number of patients with the disease. So in this example, it's the number of patients with breast cancer who had a positive MRI divided by the total number of patients with breast cancer. I'm going to give you a second to fill in the formula on your worksheet and then to do the calculations for MRI. And remember when you're filling in the formula that for sensitivity, the presence of disease is the denominator. So the formula is A over A plus C. Here it's 39 over 40, and the sensitivity is 97.5%. So that's great. Now we'll move on to specificity. Specificity is the number of patients without the disease who had a negative test divided by the total number of patients without the disease. In this example, that's the number of patients without breast cancer who had a negative MRI divided by the total number of patients without breast cancer. Again, I'm going to give you a second to fill in the formula on your worksheet. And again, remember this is specificity. So we're looking at the absence of disease as the denominator. Go ahead and fill that in and then do the calculations for MRI. D over D plus B, and it comes out to 83.8%. So now MRI, according to this data, is very sensitive at 97.5%, but not very specific at 83.8%. And I bet that mirrors what a lot of us see in the clinic. And you can see that the calculations that they did in this manuscript match ours exactly. So we're able to take data from a real life situation and apply it to come up with numbers of sensitivity and specificity and to see how it's done. Okay, so now let's calculate negative predictive value and positive predictive value. We'll start with the positive predictive value. This is the probability that subjects with a positive screening test truly have the disease. So what's the probability that someone in this study with a positive MRI truly has breast cancer? We're going to start by writing down on your worksheet the formula for positive predictive value, and I'll give you a second to do that. And remember that for positive predictive value, the denominator is going to be the result of the test. And then you can do the calculation for MRI on your worksheet. A over A plus B, so 39 over 488 is 8%. So that's really low. That means in this study, if someone had a positive MRI, the probability that they have breast cancer is only 8%. Let's do the negative predictive value. This is the probability that subjects with a negative screening test truly don't have the disease. So in this study, if someone has a negative MRI, what's the probability that they truly don't have breast cancer? Again, I'm going to give you a sec to fill that out on your worksheet. And remember that for negative predictive value, the denominator is the result of the test. So D over C plus D, and that comes out to virtually 100%. So the negative predictive value of MRI in this case is awesome. And you can see what the authors calculated as a positive predictive value of 8 is exactly what we calculated. It's pretty neat that we can use their data and do these calculations and come to the same conclusions that they come to. So now what can we tell our patient about MRI based on this? So MRI has a relatively high sensitivity. It's very likely to detect a breast cancer if it exists, but MRI has a relatively low specificity. It's not uncommon that patients will have to undergo biopsy for something that will turn out not to be a cancer. So you tell your patient that, and then she asks you, how does MRI compare to mammogram? And we can use data from the same paper to answer that question. So here I've taken similar numbers for mammogram and provided them for you. You can also get them from the paper. Now let's use them to fill in the 2x2 tables for mammogram. So we're going to go through all those same steps again. You can go to your worksheet, and this is number 2, and you can fill in your 2x2 table along with me. So we're going to start with step 1. We're going to label the columns, presence of disease, yes or no. I'll do that here and you can do it on your worksheet. Now we're going to do step 2, label the rows, test result, yes or no. Here it's the mammogram. I'm going to do that here and you can do that on yours. And now we're going to fill in the boxes. So we're going to start with the 30-75 mammogram screening rounds and put that in the total box. Then we're going to look at the 13 cancers detected by mammogram. Those are the true positives, so they go in box A. Then we're going to look at the 2 mammogram false negatives. Those go in the false negative box, box C. Then we're going to look at 276 mammogram false positives. Those go in the false positive box, box B. And again, we're going to use math to fill in the remainder of the boxes. I'll give you a few moments to do the calculations. Okay. So now let's do the sensitivity, specificity, negative predictive value, and positive predictive value for mammogram. So let's start first with sensitivity. I'm going to give you a minute on your worksheet to fill in the formula for sensitivity and then to do the calculations for mammogram. Sensitivity is A over A plus C. Here it's 13 over 15 and it's 86.5%. So the true positive rate for mammogram is 86.5%. That's lower than for MRI where it's 97.5%. And that, again, probably makes a lot of sense compared to what we see in clinics. So we're very used to saying that MRI is more sensitive than mammogram. Let's do the specificity next. Go ahead and take a second and fill this in on your worksheet. You're going to fill in the formula and then the calculations for mammogram. D over D plus B, and when you fill in the calculations, it comes out to 91%. And again, you see that see what mirrors what we see in clinic. The specificity of mammogram is better than that of MRI. Okay, negative predictive value is next. So I'll give you a second to fill in on your worksheet the negative predictive value. And you can do the calculations for mammogram. So the formula is D over C plus D, and the calculations come out to 99.9%. So in this study, the negative predictive value of mammogram is pretty great, 99%, 99.9%. For MRI, it was 100%. Clinically, there's not going to be any difference. And those are both really, really high negative predictive values. And now let's do positive predictive value for mammogram. Go ahead and fill in the formula and try to do the calculations for mammogram on your worksheet. So for mammogram, the positive predictive value is going to be calculated by A over A plus B, and it's only 4.5%. So that is super low. And interestingly, it's actually even lower than the positive predictive value for MRI, even though mammogram has a higher specificity. So we're going to talk about that in just a second. I want to introduce here the concepts of spin and snout. Spin stands for specificity rules in, and snout stands for sensitivity rules out. So we know that MRI is more sensitive than mammogram. So by the snout rule, a negative MRI should be more likely to rule out a disease than a negative mammogram. The negative predictive value is usually higher for the more sensitive test. Here, the difference between 99.9 and 100 is really small, but it is slightly higher for MRI, and that shows the snout rule. But as I'll explain in just a few minutes, this isn't the best way to show it. There's actually a better tool, a likelihood ratio, and I'll explain why it's a better tool. And then let's talk about the spin rule, specificity rules in. So we know that a mammogram is more specific than an MRI, so a positive mammogram, which is more specific than MRI, should be more likely to rule in a disease than a positive MRI by the spin rule. But here, the positive predictive value is actually lower for the more specific test. Why is that? The answer is, it's because negative predictive value and positive predictive value are dependent upon the prevalence of the disease in the population. So remember, prevalence is the number of cases present in a population at a given time. There was actually a relatively low prevalence of breast cancer in this population, especially in the mammogram group. So only 15 breast cancers in over 3,000 mammograms. That's really low. And it was a lot lower than the 55 out of 2,800 in the MRI group. And so the reason the negative predictive value and positive predictive value aren't demonstrating the spin and snout rule that well is because they're highly influenced by this prevalence. But there are other values, the positive and negative likelihood ratio, that are immune to prevalence. So they're even better to use, and we're going to go through some examples to show how they're better. And just as a side note, sensitivity and specificity are also immune to prevalence. Let's talk about positive and negative likelihood ratios. So the positive likelihood ratio is the probability that an individual with the target disorder has a positive test as compared to the probability that an individual without the target disorder has a positive test. In other words, it's the true positivity rate divided by the false positivity rate. And what's another way to say true positivity rate? Sensitivity. So another way to write this formula is that positive likelihood ratio equals sensitivity divided by 1 minus specificity. It's important to remember that the higher the positive likelihood ratio, the better the test is to rule in the disease. And we're going to see some cool examples of this. Now let's move on to the negative likelihood ratio. That's the probability that an individual with the condition has a negative test as compared to the probability that an individual without the condition has a negative test. So in other words, it's the true negativity rate divided by the false negativity rate. So the formula is the quantity 1 minus sensitivity divided by specificity. And it's also important to remember that the lower the negative likelihood ratio, the better the test is to rule out the disease. Here are a couple of thumb rules that you can use to sort of see how much a positive and negative likelihood ratio impact the probability of having the disease. I especially want to point out that a positive likelihood ratio of 2 doesn't double the probability of the disease, and a negative likelihood ratio of 0.5 doesn't half it. And the reason that I point this out is because this is actually a combination of odds and not only probability. So these are really good thumb rules to remember, that for a positive likelihood ratio of 2, that increases the probability of the disease by about 15%. Of 5 increases the probability of the disease by about 30%. And of 10 increases the probability of the disease by about 45%. Whereas a negative likelihood ratio of 0.5 decreases the probability of the disease by about 15%. Of 0.2 decreases the probability of the disease by about 30%. And of 0.1 decreases the probability of the disease by about 45%. All right, so let's put this into action. Let's look at the positive and negative likelihood ratios for MRI and for mammogram. So let's start with MRI on the left. We're going to start by calculating the negative likelihood ratio. So this is going to be example number 3 on your worksheet. So I'm going to give you a second to write down the formula for the negative likelihood ratio and start the calculations for MRI. And if you want to look back on the previous slide, that'll have the formula, or I'll give it to you in just a moment. So the negative likelihood ratio formula is 1 minus sensitivity divided by specificity. So here we're going to calculate it, and it comes out to 0.03 for MRI. Now for MRI, let's do the positive likelihood ratio. I'm going to again give you a moment to write down the formula on your worksheet and then to do the calculation for MRI. So the formula is sensitivity divided by the quantity 1 minus specificity. And we can plug in the numbers from MRI here, and we get a positive likelihood ratio of 6. All right, let's go over and do the same for mammogram. So this is going to be example number 4 on your worksheet. So now you can write in the formula for negative likelihood ratio on the worksheet. Again, it's 1 minus sensitivity, that quantity, over specificity. and you can fill in the numbers for mammogram. And after you do the calculations, it's going to come out to a negative likelihood ratio of 0.15 for a mammogram. And finally, let's do the calculation for positive likelihood ratio. You can fill this in on your worksheet as more repetition for the formula for positive likelihood ratio. And then start the calculations for mammogram. Positive likelihood ratio is sensitivity divided by the quantity 1 minus specificity. And when we do the calculations for mammogram, it comes out to 9.6. So now let's look at positive and negative likelihood ratios and how they demonstrate spin and SNAP. So an MRI is more sensitive than mammogram. A negative MRI is more likely to rule out breast cancer than a negative mammogram. We can see this because the negative likelihood ratio for MRI is 0.03, which corresponds to 45% decreased probability of having breast cancer. That's lower than the negative likelihood ratio for mammogram, which is 0.15, and that corresponds to a 30 to 45% decreased probability of having breast cancer. So the negative likelihood ratio for MRI decreases the probability of having breast cancer more than the negative likelihood ratio for mammogram. So having a negative MRI decreases the probability of having breast cancer more than a negative mammogram. And there you go, that's the SNOUT rule. We know that mammogram is more specific than MRI, and a positive mammogram is more likely to rule in a disease than a positive MRI by the spin rule. And we can show that because the positive likelihood ratio for mammogram is 9.6, which corresponds to a 45% increased probability of having breast cancer. And that's higher than the positive likelihood ratio for MRI, 6, which corresponds to a slightly greater than 30% increased probability of having breast cancer. So here you go, if you have a positive mammogram, that increases the risk of having breast cancer by about 45%. Whereas for a positive MRI, it's by just over 30%. So there you go, that's the spin rule. I'm going to take a second to talk about receiver-operator curves. ROC curves are graphical plots that illustrate diagnostic ability of binary tests, and you make these by plotting on the x-axis the true positive rate or sensitivity, and on the y-axis the false positive rate or 1 minus specificity. The most ideal test has a super high sensitivity and a low false positive rate, and it's going to end up in the upper left-hand corner of the plot. Let's give a little example. We're going to use the numbers from MRI and mammogram. For MRI, the sensitivity is 0.975, and the false positive rate or 1 minus specificity is 0.162. For mammogram, sensitivity is 0.865. For false positive rate, 1 minus specificity is 0.09. And if we plot them on a receiver operator curve, you can see that MRI has a higher sensitivity than mammogram, but also has a higher false positive rate. Whereas mammogram has a lower sensitivity, but also has a lower false positive rate. And the most ideal test would have numbers way up with the highest sensitivity and the lowest false positive rate. So now, based on all this, what can you tell your patient about MRI versus mammogram? You can tell her that MRI is better than mammogram at detecting cancer, and if her MRI is negative, she probably doesn't have breast cancer. You can tell her that MRI also leads to more biopsies for non-cancers than mammogram. You can tell her that her mammogram is positive, she's more likely to have breast cancer than if her MRI is positive. And so you have this conversation with her, and then she asks you, but how does my family history play into this? So let's talk a little bit about pre- and post-test probability. Pre-test probability is the probability of the target disorder before a diagnostic test is ordered. It's also the prevalence of the disease. And I'm going to take a second here to just give a quick note about probability versus odds. This is a really important concept that it applies to this lecture, but also to other biostats lectures. So probability is another word for chance, whereas odds is a comparison of events against non-events. And so a really great example to be able to show how probability and odds are different is just with a dice. So you have a fair dice and you roll it. Your probability of rolling a 1 is 1 in 6. So it's about 16.67%. And that's very different from your odds of rolling a 1, which are 1 against 5, which is 0.2. The probability is almost always expressed as a percentage, whereas the odds can be expressed as a decimal place. And you can see how they're different here. All right, so let's go back to the pretest probability. Pretest probability can be converted to pretest odds, which are the odds that the patient has the target disorder before the test is carried out. And you do this with the formula pretest probability divided by 1 minus post-pretest probability, or you can do it with prevalence, as prevalence divided by the quantity 1 minus prevalence. So you can take those pretest odds and you can actually calculate post-test odds using the likelihood ratio. So post-test odds are the odds that the patient has a target disorder after the test results are known. So we calculate this by the pretest odds times the likelihood ratio. And then you can take those post-test odds and you can convert the post-test odds to post-test probability. And you can do that by taking the post-test odds and dividing it by the quantity post-test odds plus 1. And we're going to show some examples of this so you can see it in action. All right, so let's talk about post-test probability of MRI and mammogram. And we're going to start by doing this as an example of a positive test in someone who doesn't have a family history of breast cancer. So let's start with MRI on the left. And we're going to start with a positive MRI using the positive likelihood ratio. So let's say we have a patient that doesn't have a family history of breast cancer. I'm just going to arbitrarily say her pretest probability of breast cancer is 12.5%. It's actually the lifetime risk, but I'm just going to use this number here as an example to illustrate the concepts. So we're going to take that pretest probability and we're going to convert it to pretest odds. So we do pretest probability divided by the quantity 1 minus pretest probability, and that takes the pretest probability of 12.5% and changes it over to the pretest odds of 0.143. Now we're going to calculate the post-test odds by multiplying the pretest odds times the likelihood ratio. So 0.143 times the likelihood ratio of 6 gives you 0.857. Now we're going to take those post-test odds and make them a post-test probability. And we get 46%. So what does that mean? That means if somebody comes into the clinic, has a pretest probability of breast cancer of 12.5% and has a positive MRI, her post-test probability of having breast cancer is 46%. Now let's compare it to the positive mammogram. So here's the positive likelihood ratio of mammogram, was 9.6%. We start with the same patient with a pretest probability of 12.5%. You get the pretest odds. Now we calculate the post-test odds. So this is the pretest odds times the likelihood ratio. We get 0.143 multiplied by 9.6 gives us 1.37. And then we take those post-test odds and convert them to post-test probability, and we get 58%. So here you have the same patient. She had a pretest probability of 12.5%. She has a positive mammogram, and now her risk is 58%. It's higher than it would have been with just a positive MRI because the mammogram is more specific. So here's this cool concept in action. All right, so let's see how family history impacts this. Over on the left is the calculation we just did for mammogram in a patient with a pretest probability of 12.5%. Now let's say that family history increases your pretest probability to 20%. Again, that's a lifetime risk that's commonly used, but I'm just using it here to illustrate the example. So let's take that pretest probability of 20% and make it pretest odds. It comes out to 0.25. And let's calculate her post-test odds if her mammogram was positive. So we take 0.25 and we multiply it by 9.6 and we get 2.4. And now let's take those post-test odds and make them a probability. And we get 71%. So you can see how a mammogram in someone with a higher pretest probability because of family history of breast cancer leads to a higher post-test probability. All right, so let's talk a little bit about negative likelihood ratios and do a similar example. So we're going to start with, again, with MRI, and the likelihood ratio with a negative MRI is 0.03. And now let's start with the patient that doesn't have a family history of breast cancer. So again, we kind of arbitrarily said her pretest probability was 12.5%. We converted that to pretest odds. Now let's throw in that negative likelihood ratio. Take those pretest odds of 0.143 and multiply them by the negative likelihood ratio, and we get 0.0043. Now let's convert it to probability. We get 0.4%. So look at that. Now someone has a negative MRI, and her post-test probability of having breast cancer is less than 0.5%. That's super, super, super low. So that's because this is such a sensitive test, its ability to rule out is so good. Now let's compare that with mammogram. So here we have the negative likelihood ratio that was 0.15. We calculated that earlier. We got the same patient, pretest probability 12.5, pretest odds 0.143. Now let's calculate those post-test odds, which is pretest odds times likelihood ratio. So we got 0.143 times 0.15, we get 0.215. Now let's take those post-test odds and make them a post-test probability. And here we get 2%. So if someone doesn't have, has a baseline risk of pretest probability of 12.5 and they have a negative mammogram, their risk of having breast cancer is low. It's only 2%, but it's not nearly as low as it would be with a negative MRI, which would have been 0.5%. So you can see how in this population, the negative MRI is better at ruling out the disease. All right, one more cool example. And this is actually number 5 on your worksheet, so you can follow along and do this one. On the left-hand side of the screen here is the test that we did previously with the negative likelihood ratio in a patient with a pretest probability of 12.5%. Now let's do that same calculation in a patient with a family history of breast cancer. And again, we're going to say that her pretest probability is 20% because of that family history. Let's take that pretest probability and make it pretest odds. There's that 0.25 again. And now we can calculate the post-test odds. So this is where that likelihood ratio comes in. So you got 0.25 times 0.03 and we get 0.0075. And let's make those post-test odds a probability and we get 0.7%. So you got this woman who comes in, she's got a family history of breast cancer, so she gets an MRI. And now if the MRI is negative, so now her post-test probability is less than 1%. So that's pretty cool. The MRI is really good at ruling out breast cancer, even with a higher pretest probability. Now, because her pretest probability was a little bit higher from her family history, her post-test probability is not quite as low as the woman who didn't have a family history, but it's still pretty darn low. So regardless of the pretest probability, a really sensitive test is still awesome at ruling out the disease. All right, so let's go back to our patient. What can we conclude for her? We can tell her, she asked about her family history. We know that family history increases her pretest probability of having breast cancer. So if she has a pretest probability of breast cancer at about 20%, a positive MRI increases the probability of having breast cancer to 60%, and a positive mammogram would increase it to 71% because the mammogram is more specific. But where the MRI is really helpful is that even if she has a pretest probability of breast cancer of about 20%, a negative MRI decreases the probability of having breast cancer to less than 1%, to 0.7%. And a negative mammogram alone would have only decreased it to about 3.6%. So here is the real benefit of MRI for this woman. Just a quick note that there are really other important factors that go into determining which screening test is best, including ability to detect cancer earlier at a lower stage. But sensitivity, specificity, and likelihood ratios are a really critical part of choosing the best screening tests and the best tests in different situations for diagnosis. And I hope that this has been a really valuable example in showing why this is really important for how tests are recommended and chosen, and how it's important for explaining this to our patients in clinic. Let's move on now to survival analysis. Survival analyses are extremely important in what we do in radiation oncology. We see them all the time when we're reading and interpreting published results of clinical trials, and we reference them all the time when patients ask their chance of survival following diagnosis and treatment. So there are some resources for this portion of the talk. The first is a survival analysis worksheet that you can use to follow along to do a Kaplan-Meier calculation. The second is a spreadsheet for survival analysis that contains 4 sheets of each of the tests that we're going to use. The next is just a website to download R. This is going to be a mini tutorial on how to do survival analyses in R. I've used R here because it is available for free to everyone, and you can easily find directions on how to do simple survival analysis coding online. And then I'm just going to use the cross trial as a practical example of survival analysis. So this is what the worksheet looks like on the left, and this is what the spreadsheet survival analysis looks like on the right. At the bottom, you can see that there are 4 tabs: Kaplan-Meier 1, Kaplan-Meier 2, log rank 1, and Cox proportional hazard 1. So survival analysis use time to event data. With time to event data and survival analyses, the dependent variable is not just a dichotomous outcome. So we're not just looking out at whether a subject is alive or dead, or whether there's been a recurrence or no recurrence. Time to event data and survival analyses incorporate a temporal element to the outcome. And therefore, these types of analyses look at how long a subject survives, or time to recurrence. The commonly used time to event analyses in oncology are Kaplan-Meier curves, the log rank test, and I'll also talk briefly about the Wilcoxon test, and the Cox proportional hazards model. Kaplan-Meier curves are the most basic analysis of time to event data. Kaplan-Meier analyses incorporate information from all observations available, and they consider survival at any time point as a series of steps. So an analogy to think of is a toddler who wants to get from a chair to a table. It takes about 5 steps to get from the chair to the table, but in order to make those 5 steps from the chair to the table, the toddler first has to take the first step successfully. The second step can only be taken if the first is successful, and the third can only be taken if the second and therefore the first are successful, and so on. In this way, survival analysis estimates conditional probabilities of successful steps and then multiplies them together to obtain an estimate of the actuarial overall survivorship function. Kaplan-Meier curves have a couple of nuances that are important to understand. The first is that when we do these analyses, the time points, everyone doesn't start at the same time. And everyone's not in the study for the same amount of time. And so this complicates the analysis. And this is a nice schematic that shows that if we compare, for example, the subject marked D and the subject marked B, the subject marked D is enrolled first at the very start of the study, and that subject's follow-up ends at 4 months. And compare that to subject B, who starts in enrollment at 2 months, and then the follow-up ends at 10 months. So the subject B is actually in this analysis longer for 8 months than the subject D, even though subject D was enrolled first. Another important nuance of Kaplan-Meier curves is that there are basically 2 ways that data can end being collected on a patient. The first is an event or a failure. And so in the case of a survival analysis, an event or a failure is death, and here that's shown by an X. If a subject experiences this event or failure, then they've reached the endpoint and they're no longer followed. But in some cases, patients are followed and they never reach this event or failure, but data is no longer collected. And that can happen for a couple of reasons. For example, here, subject C, that stopped because the end of the study was reached and data collection ended. But you can also look at subject A, who enrolled at 4 months, had a follow-up at 6 months, and then no more follow-up after that. That patient had no more data collected, probably because they either were lost to follow-up or they withdrew from the study. This type of endpoint is called a censor, and this happens when the event does not occur for a subject during the time that they're being followed. Here's a further explanation of censored and event or uncensored data. So censored data is incomplete data. Data is censored when there's been follow-up for a certain period of time without an event or a failure occurring. Data can be censored if study follow-up has ended and no event or failure has yet occurred, if the patient is lost to follow-up, or if the patient withdrew from the study. Censored data is different than an event, also known as a failure, uncensored data. Uncensored data is when the specified endpoint of the study is reached. For overall survival, the pre-specified event in question is death. For progression-free survival, the pre-specified event in question is either progression of disease or death. So a Kaplan-Meier curve is a conditional probability curve created using time to event data. And I think it would be very nice to use an example. The example that I'm going to start with is a phase 2 trial of pembrolizumab in patients with metastatic non-small cell lung cancer who have progressed on first-line systemic therapy. I'm going to use an artificial data set, and we're going to expand on that to go through the different types of survival analyses. For this phase 2 trial, a Kaplan-Meier would be used to create an overall survival curve. The primary endpoint we're going to look at is overall survival, and we're going to do an interim analysis of the first 10 patients of this artificial data set. So here's the data set, and you can follow along and see this data set on the worksheet. The data set gives the patient number, the enrollment date, the last follow-up date, the survival status as alive or deceased, the date of death, and a column for whether or not the patient was censored or had an event. I just want to point out that the enrollment dates range from January 2012 to June 2012. So here we see patients are enrolled over time, not all at the same time, as previously discussed. And just to clarify, that alive means censored at date of last follow-up, and deceased means that they've had the event of death at the date of last follow-up. So I'm going to give you a moment to fill in your worksheet the censor versus event column. So let's go through the steps for the Kaplan-Meier curve, and you can follow along on your worksheet. So the first step is to determine the time. Here I'm going to use the number of months that each patient remains in the data set before being censored or before dying, which is the event. Here I've filled in the number of months using the enrollment date and then subtracting from the date of last follow-up. I recorded them here in whole numbers of months so that this is a very manageable calculation that we can do by hand. I'll show you later how we can use fractions of months. So here the patient had to reach the number of months to be included. So for patient 1, the follow-up was actually a little longer than 17 months, but because 18 months wasn't reached, I used 17. And again, this is for ease of calculation, and later we'll use an example that uses fractions of months. All right, so step 2 is to reorganize the data in order of the shortest time in the study to the longest time in the study. So for this data set, patient number 6 was in the study for the shortest amount of time at 9 months, and patient number 8 was in the study for the longest amount of time at 18 months. Step number 3 is to look at the time intervals, the time passing between changes in the number of patients remaining in the study. So I'm going to have you follow along on the worksheet for this too, because this is sort of the important critical understanding of how to fill out and perform the Kaplan-Meier analysis. So the first time that we see a change in the number of patients in the study is at 9 months. So our first time interval is from 0 to 9 months. At the beginning of that time interval, there are 10 patients at risk. And then during that time interval from 0 to 9 months, there is 1 death because patient number 6 has an event at 9 months, and no patients are censored. So at the end of the time interval, there are 9 patients surviving. And then from 9 to 12 months, we start off with 9 patients because patient number 6 had an event, so now we just have 9 patients remaining. And then there is one event. So patient number 10 has an event. No patients are censored. And at the end, there are 8 patients. Then from 12 to 13 months, we start with 8 patients. 1 patient dies, none censored. And we end the period with 7 patients alive. And I'm going to have you keep following along on the worksheet as we go. From 13 to 14 months, we start with 7 patients alive, none are censored, 1 dies, and then there are 6 at the end. Then from 14 to 16 months, this is the first time that we see a patient censored. From 14 to 16 months, we start off with 6 patients at risk, then we have 1 die and 1 censored. So at the end, there are 5 that are surviving, but then at the start of the next time period from 16 to 17 months, there are only 4 at risk because 1 was censored during the last time period. Then from 16 to 17 months, again, we start with 4 patients at risk. There are actually no deaths and 3 patients are censored. So at the end of this time period, 4 patients are surviving because no one died. But then as we get to 17 to 18 months, there's only 1 patient at risk because 3 more had been censored. And during this time period, no patients die, 1 is censored, and at the end, 1 patient remains surviving. Step number 4 is to calculate the Kaplan-Meier estimate as a probability estimate for each time period, except the first, as a compound conditional probability. So from 0 to 9 months, we start with 10 patients at the beginning, and then after 9 months, we have 9 patients. So the probability of surviving is 9 out of 10, or 90%. From 9 to 12 months, we start with 9 patients, and then we have 1 death. So at the end, we have 8 of 9 patients surviving, which is 89%. But remember, the chance of surviving 9 to 12 months is conditional upon having survived the first 0 to 9 months. So the actual conditional probability of surviving 12 months is actually 90% multiplied by 89%, and that gives us 80%. Then from 12 to 13 months, we start with 8 patients and 1 patient dies. So from 12 to 13 months, the probability of surviving is 7/8 or 87.5%. But again, that's conditional on having survived 9 to 12 months and 0 to 9 months. So the actual conditional probability of having survived 13 months is 90% times 89% times 87.5% or 70%, and so on and so forth. So after we've done these calculations, we can actually plot the survival graph. And what this means is exactly what we just talked through, and I'm going to talk through it again using the graph. I'll also point out that in this graph, there are a total of 5 steps, and that's because there are 5 events. So you have a step for each event. So the way we interpret this Kaplan-Meier curve is that the calculated estimate for surviving 9 months is 90%. If a patient survives 9 months, then the probability of surviving 3 more months to 12 months is 89%. But for surviving from 9 to 12 months is conditional on having survived the first 9 months. So together, these estimates lead us to conclude that the estimated probability of surviving 9 months and then surviving another 3 months to 12 months is 80%. If a patient then survives the first 12 months, the probability of surviving yet another month to 13 months is 87.5%. But surviving 12 to 13 months is conditional on having survived to 9 and to 12 months. So the estimated probability of surviving 12 months and then surviving another month to 13 months is 70%, and so on. The median survival is a really critical time point to understand. This is the time point on the Kaplan-Meier curve at which the probability of surviving is 50%. So what is the median survival in this data set? We're going to go to 50% and then look and see that the curve hits 50% at 16 months. So the median survival here is 16 months. So if a patient with non-small cell lung cancer and Pembro asks you, how much time do I have? You can say that 50% of people survive about a year and 4 months. All right, so now we can do the same thing in R. As I said earlier, R is a statistical program that's available to be downloaded for free. There are many other statistical programs that can do this analysis. I've just chosen to use R because of its availability and also because it's really pretty easy to find code to do survival analysis. What I've tried to do here is I don't expect you to be able to follow along and actually do the calculations in R while I'm doing them. So I have tried to type all of the R commands with the prompt in purple and the code in blue. And then I've also cut and pasted the R sheet to show you how it works. This way you can do these analyses in R on your own as practice, or you can apply to a data set that you're analyzing as well. To do this, you need R version 3.4 or higher, and then you want to install the survival packages. And these are the commands to do that. And here you can see I used R version 3.63. And I installed the survival and the survminer packages. The data set we're going to use for this is the Kaplan-Meier 1 data set from the survival analysis Excel spreadsheet. I'm just going to point out here that this data set uses the survival in whole months. Again, we're going to look at using fractions of months in just a moment. I just want to show you that the hand calculations we did are going to give us the exact same results as the calculations in R. Of course, R does it with a lot less manual work on our part. So to start, you're going to save the data as a CSV file, and then you're going to change the working directory in R and save the CSV file, and you can name it Kaplan-Meier 1. And these are the commands, and this is how it works. And you can see that R pulls up the exact data set that we had just done the calculations on. So then in R, you're going to perform the serve and serve fit functions. This is how you do it. You're going to define the event as the survival status column. One defines one as an event. So the critical things to have in a data set for a Kaplan-Meier analysis are the follow-up. Here we did follow-up in months, and the survival status, whether the patient is alive or there's an event. This follows exactly what we just did with the previous calculation. Then you're going to do the serve fit function and then plot the serve fit function. And I'll show you what that looks like. First, when you do the serve function, what it does is it breaks the data into time points in months, and then it puts a plus sign next to every month where a patient was censored. And this is basically what we did with our first step in our Kaplan-Meier calculation. Next, you do the serve fit function, and that gives the number of events in the median survival. And as you can see, this is the same data set we used, and the median survival is 16 months, just as we calculated. Also gives the 95% confidence intervals. And then this last plot function is the command for creating the Kaplan-Meier curve. So now I want to move on to Kaplan-Meier 2 data set, because this uses the true follow-up time with months, including fractions of months. Because with a statistical program, it's really easy to do these calculations. So again, with a Kaplan-Meier 2 data set, the information that's really important to have to be able to do the survival analysis in R is the follow-up time. Here I've done it in months, and I've calculated months in Excel by doing the days 360 function divided by 30. And then the survival status with 0 being a censor and 1 being an event. And again, we tell R that 1 is an event within the function. So again, you're going to save this data as Kaplan-Meier 2 as a CSV file. You're going to change the working directory in R to wherever you've saved it. I did it on the desktop. Then you're going to name it Kaplan-Meier 2, and you're going to do the serve and serve fit functions and plot the serve fit function. And here it is. This is the plot for the Kaplan-Meier 2 data set. It's a survival curve. And these two survival curves from Kaplan-Meier 1 and Kaplan-Meier 2 are very similar. But if we go back, we can see that the median survival here is 16.8 months, and that's because we have used months with fractions of months to be a little bit more precise in our timing. So looking back at the two Kaplan-Meier curves, Kaplan-Meier 2 on the left has 5 steps because there were 5 events, and Kaplan-Meier 1 on the right has 5 steps because there were 5 events. The median survival is similar, but it's a little bit longer, 16.8 in Kaplan-Meier 2 versus 16 in Kaplan-Meier 1, and that's because of the use of fractions of months. So the curves are slightly different, but generally very, very similar. All right, so let's move on to the log rank test. So this gets into the sorts of things that we're often looking at when we're looking at whether or not certain factors impact survival. So if a patient is treated, if they're likely to survive longer than if they are not. So the null hypothesis that for any log rank test is that there's no difference in time to a particular event between 2 groups, because the log rank test is used to compare time to event data between 2 groups. We're going to use an example of a randomized trial of SBRT in addition to pembrolizumab in patients with metastatic non-small cell lung cancer who have progressed on first-line systemic therapy. We're going to use a log rank test to analyze survival and compare survival among 2 groups. So in this example study, we have patients with metastatic non-small cell lung cancer who have progressed on first-line systemic therapy, and they're randomized to pembrolizumab or pembrolizumab plus SBRT or SAVR. The primary endpoint is overall survival. The accrual here is 20 patients. Again, this is an artificial data set that I've used with 20 patients to be able to do this analysis. So here's the data log rank 1 from the spreadsheet. Again, it's really critical for these survival analysis to have follow-up. Here it's in months. Survival status with 0 being a sensor and 1 being an event. And for a log rank test, you also have to add a variable for comparison. And here it's SBRT. So for the first 10 patients that are the patients we analyzed for the Kaplan-Meier, they did not have SBRT, so their status is 0. And so for the patients 11 through 20, they did have SBRT. So their SBRT status is 1. So we can analyze this in R. Again, we're going to save the data set as a CSV file, change the working directory in R, and save the data set as log rank 1. Here is the R commands and file, and here's the data set, the same one that I had just showed you from the Excel spreadsheet. All right, now we're going to perform the survfit function in R. And again, we need the follow-up in months and the survival status, and we need to define 1 as event. Then we're going to perform the survfit function that's going to give us the median survival and 95% confidence interval for each group, divided by basically divided by SBRT status. Then we're going to name the survfit function and then perform the survdiff function and plot the survdiff function, which is the log rank test. So here is the information from R. First, the survfit function for the whole group gives us an N of 20, 6 events, a median survival of 18.7 months. Then we're going to do the survfit function by SBRT. So this shows patients who did not get SBRT. So that's that first group that we already analyzed. Their median survival was 16.8. That's exactly what we got in our Kaplan-Meier analysis. And then for the patients who did get SBRT, there's only 1 event, and the median survival was not applicable, and it gives the 95% confidence intervals. Then we can pull up the survival function, and we see each time point in months, and a plus sign means that a patient was censored at that time. Then we do the survdiff function, and this is going to give the chi-square and the p-value. So for our example, the p-value is 0.01. And so what we can conclude from this is that SBRT is associated with statistically significantly higher survival, longer survival than not having SBRT in this group of patients. So here we've been able to compare 2 groups in R. And we can plot that, and we can plot it and have a legend that shows the SBRT group, and you can see that for them, median survival isn't reached. And the no SBRT group, which is the group we analyzed in our Kaplan-Meier example, and the curve looks the same, and the median survival is 16.8 months. And we know from the previous page that there is a statistically significant difference between the survival of these two curves and that the p-value is 0.01. I just want to say very quickly a little bit about the Wilcoxon rank sum test. The Wilcoxon rank sum compares time to event data between two groups when censored data is not present. This is different than the log rank test that we just went through. The log rank test is most appropriate when censored data is present. And censored data is very common in what we do, so the log rank test is used much more often and is much more important for us to understand. Now let's move on to the Cox proportional hazard model. This is what you see all the time when you're reading papers about randomized trials. This is a survival model that analyzes time to event data while taking the effect of covariates into account. It's a regression that allows us to assess the effect of covariate predictors on the shape of the survival curve. And what's really nice is that covariates can be both categorical or continuous. The null hypothesis of a Cox proportional hazard model is that there's no difference in the time to a particular event based on each covariate. Another way of saying this is that the regression coefficient for each covariate is 0, or that the hazard ratio for each covariate is 1. So let's do an example, very similar to the one we just did. Now this is a randomized trial of SBRT in addition to Pembro in patients with metastatic non-small cell lung cancer who have progressed on first-line therapy. The Cox proportional hazard model will be used to analyze survival and compare survival among multiple groups between two groups or multiple groups while accounting for covariates. So our patients are patients with metastatic non-small cell lung cancer who have progressed on first-line systemic therapy. They're randomized to Pembro versus Pembro plus SBRT or SABR. The covariates we're going to look at are gender and SBRT. The primary endpoint is overall survival, and here I've used 40 patients because you need a little bit of a bigger data set to do this, because generally you need enough events to account for each covariate. So when we're thinking about a Cox proportional hazard model, we're going to start by considering a baseline survival curve, which is survival of an average patient with metastatic non-small cell lung cancer who has progressed on first-line systemic therapy, now receiving Pembro. And the slope of the curve is changed by predictor variables such as gender, age, and treatment with SBRT. For this example, just to keep it simple, we're going to look at gender and treatment with SBRT. And what the Cox proportional hazard model does is it eventually, first it computes a regression coefficient and then ultimately a hazard ratio for each of these covariate predictors that assesses the rate of death based on the influence of each of the covariate predictors. A hazard ratio is really important to understand. It's the ratio of the risk of the event over a certain period of time for different categories of covariates. And it is calculated by taking the chance of an event occurring in the treatment arm divided by the chance of an event occurring in the control arm, or you can actually do it vice versa, but it's usually done as the chance of the event divided by the chance of the event in the treatment arm divided by the chance of the event in the control arm. The closer to 1 the hazard ratio, the less effect the covariate has on the curve. A hazard ratio greater than 1 is associated with a greater likelihood of the event, so it's greater mortality on an overall survival curve. A hazard ratio less than 1 is associated with lesser likelihood of an event, so that would be greater survival on an overall survival curve. So a hazard ratio less than 1 is what we want to see, and in almost every case, a hazard ratio less than 1 is great. So here is the data set we're going to use for analysis. This is the Cox proportional hazard model. For this, we need to have the follow-up time in months, their survival status, the SBRT status, and then we're also going to add the covariate of gender, but theoretically you could add as many covariates as you wanted to look at. So we're going to analyze in R. We're going to save this data set as a CSV file and then change the working directory and name the data set Cox proportional hazard model. And here's doing that, and you can see the data set's imported. We'll start with univariate regression just to do it step by step. We'll start with gender. We're going to use the coxph command and name the function. I named it rescox. Then we're going to get a summary of that, and that is going to give us a p-value for the univariate covariate, the hazard ratio for the covariate, and the likelihood ratio test for the model. And then we can repeat the same example with SBRT. So here you go. On the left is gender. And you can see the results. So the hazard ratio is 0.7779 for gender, and the p-value is 0.67. So gender does not have a statistically significant impact on this. And then also the model is not statistically significant for gender. Next, we'll go to SBRT. Here, the hazard ratio is 0.22, and the p-value is 0.024. And so SBRT is a predictor of survival. And this makes sense because that's what we saw when we did the log rank test. And then when we look at the overall model, that p-value is also statistically significant. So gender is not a predictor for overall survival in this data set on univariate analysis by Cox regression, but SBRT is. So SBRT has a statistically significant impact on survival as a univariate coefficient. So now let's move on to multivariate regression. We have to name our covariates and then use Cox formulas and models and then get the results. The results are going to give us the p-value for each covariate, the hazard ratio, and the likelihood test. So here is the information that we got after entering the covariates and doing the formula and models. And it gives us a p-value for each covariate. So the p-value for gender is not significant on multivariate regression, but the p-value for SBRT is. And we get a hazard ratio, and the hazard ratio for SBRT is 0.22. So that's essentially a 78% reduction in mortality with SBRT in this data set. And the p-value for the overall model is just less than 0.05 on the likelihood test ratio. The likelihood test ratio is appropriate for a small data set like this. You can also get the Wald and other p-values for models too. So again, we talked about hazard ratio earlier, and we learned that a hazard ratio of greater than 1 is associated with greater mortality, and a hazard ratio of less than 1 is associated with greater survival. So the hazard ratio here for SBRT was 0.22, and that's about a 78% decrease in risk of death. So just as we had talked about earlier, this hazard ratio less than 1 is great for SBRT because we see that it statistically significantly is associated with improved survival in multivariate regression. So we see Cox proportional hazard models much more complicated than that all the time. And I thought I'd use the cross trial. I'm sure you guys all know this trial, randomized trial of the addition of neoadjuvant chemoradiation to surgery alone. And here's the output of the publication. So they say in the methods section of this paper that they use the Cox proportional hazards model. And I like this survival curve because you can see how they're able to make curves for 4 different groups. Generally, log rank tests will only give you 2 groups, but if you want to look at 4 like this is where you need to use the Cox proportional hazard model. And just to call into practice, we get the median survival for each group by looking at the 50% survival. So for the squamous cell carcinoma with surgery alone, that median survival is the lowest. And it looks like less than 24 months. And the median survival for the adenocarcinoma with chemoradiation followed by surgery is actually not even reached. And then finally, I just want to show you how the hazard ratios are reported in this study. So you can see that the hazard ratio for chemoradiation is less than 1 in almost every subset by almost every covariate. But we want to look at the ones that don't cross 1 as the ones that are statistically significant. So male gender, adenocarcinoma, clinical stage N0, and WHO performance status 0. So again, survival analyses are around us all the time, and it's really important to be able to understand them in depth. I really enjoyed learning how to do the calculations, and I hope this has provided some insight into these important analyses that are critical to what we do.